Good morning, good afternoon, good evening, no matter where you are. We are really excited to see you all in this virtual space. My name is Pedja Stojicic, and I'm the Executive Director of People Power Health and also one of the founding members of Courageous Clinicians Community. This is our first in the series of what we call Courageous Conversations, where we're going to invite amazing people to have conversations with both of our community, but also beyond that and share it with broader audiences that are important for, courage that we need to find as clinicians, as public health professionals to do this work. And then since I've said that this is the really special conversation for us, first in the series, we also have a special guest today. We are joined by a man who somehow manages to be a physician, a poet, I would call a public health revolutionary, a modern day prophet for primary care, and all of that in one person, if you believe me. So Dr. Michael Fine, he's a former health director for Rhode Island. So he had also a public service background, a family physician who spent decades in both working in the clinic, but also on the streets organizing for justice. He believed that, and I will quote you here, Michael, that healthcare should be like electricity, universally available, reliable, and boring. And then we can all get to live our lives. And, here's here today, and we were preparing for this conversation to really make us inspired, to laugh, to think, and maybe, and I hope it's not just maybe, sign up to save primary care in United States of America. So please welcome and give a big round of applause to Dr. Michael Fine. So hi, Michael. Good to see you.
Thank you for having me.
So I want to start this conversation by getting straight to the point. And this might sound like a silly question, but if I was someone who is coming from, let's say, Sweden, because we have in our community, we have people from all around the world. And I have my own experience, my own lived experience of what is primary care and how is it organized and whatnot. How would you describe state of affairs when it comes to primary care in America? What would you say to me to describe where we are right now and what's going on with primary care in this country? And how should I even think about it as I'm starting to live here?
It's a desperate, failing mess. And it's heartbreaking because we have 30 or 40 years of evidence that shows that health care systems that have a greater number of primary care per 10,000 people, where more people have access to primary care, are the healthcare systems that are most effective from a public health perspective and also most affordable. Here in the United States, we have neither effectiveness nor affordability. Our health outcomes, our public health outcomes rank us 50th in the world, even though we spend about twice as much as the average of other advanced nations. And at the same time, now fewer than 43% of American adults have a primary care relationship. Our primary care colleagues are exhausted. They're dropping out. Nobody can find primary care doctors or primary care practices. So we have this, huge potential opportunity to create a healthcare system that takes care of everybody. And yet we're failing. And that's the sort of daily heartbreak.
Yeah. And when you think about it, Michael, what do you think is causing that? What's the reality that we are all need to face in order to kind of understand why in this, one could argue the richest country in the world, by any standard, why do we have that when it comes to primary care? What's the cause of that?
There are proximal and distal causes like anything else. So more proximal causes are things like, because of the way the medical industry works in the United States, understanding it's all for profit, primary care clinicians are paid less well than other physicians. So people don't go into primary care as much. So, our medical schools, only about 20% of graduates of medical schools or fewer seek primary care careers. We don't have enough medical schools. One of the dirty little secrets of healthcare in the United States is that 25% of all our physicians come from other countries. We are basically draining other countries of physicians because we're not producing enough. I mean, we have at least 25% more to produce and probably more than that. So we don't produce enough. We don't have enough residency programs. We have created an electronic medical record system that causes our colleagues to work endlessly, to look at their computers, not listen to their patients, to stay up all night. We talk about something called pajama time, so that people see patients all day and then go home at night, and in their pajamas are up till midnight, like entering things into the computer, kind of clickbait, it's called. And most of that clicking doesn't have anything to do with patient care. It's really about supporting the billing process supporting the for-profit nature of healthcare at the end of the day. So, those are the proximal causes. The distal causes are two, as I see them. One is that we have allowed profit to enter the healthcare process, which ought to be not for profit and for people instead. And the other is that nobody is in charge. We don't have a Ministry of Health that's responsible for getting people healthy. We've got an alphabet soup of bureaucracies that don't talk to each other. And so nobody's out there sitting out there thinking, what kind of clinicians do we need? Where do they need to be? How do we make sure everybody has a clinician? None of that happens. Basically, everybody gets to make it up on their own. And with absent leadership, there is no ability to create a system that takes care of everybody.
That is really interesting. And I wanna double click on something and maybe just not necessarily disagree with you, but invite you to comment on that, because it has been on my mind. You said something about medical schools and shortages of doctors. But there's an argument out there that primary care has its components that needs to be provided by doctors, but also a lot of it can be provided by nurses and others. So how do you think about that? We have a lot of nurses in our community, and I'm always thinking about the balance and connection between the two, and even beyond that, others as well who are involved in provision of care.
There are a couple of answers. One is that, in the United States, we have nurse practitioners, people who are nurses who have clinical training, and we have physician associates or PAs, another pathway to become clinicians. And when those people come out of training, most of them leave primary care anyway, because the life is so difficult. So that's one piece. The other piece is we have not well structured community health, and we have not well structured multidisciplinary teams. So, it used to be there was a community health function in the United States. It was actually, interestingly, funded by an insurance company, by Metropolitan Insurance Company. It was called district nursing, and every place had a nurse whose job it was to sort of know everybody in the community, make sure all the kids got immunized, even if that person didn't do it themselves, and sort of kept an eye out for elders and made sure that everything was okay. That system kind of went away 40 or 50 years ago. And so much so that no American, there are probably 10 of us who remember that it even existed, because it wasn't a medical process, it was a nursing process. And so nobody kind of held it wholly. I have a couple of nursing colleagues who know about it, but that's about it. So, and then many of us understand or believe that the most effective primary care is provided by multidisciplinary teams, that practices should have community health workers and physical therapists and pharmacists, and physicians and nurses all practicing together, some doing first contact care, others doing chronic disease management, nutritionists for nutritional education, et cetera, et cetera. And there are a couple of places where that happens, but it's catch as catch can, because nobody's in charge of saying every community of 10,000 people needs one of these great multidisciplinary practices, and nobody's in charge of making sure we have the workforce to support it, and nobody's in charge of making sure that they're paid in a way that makes the care they give sustainable. It's all chaos.
Yeah, really, like you're answering my next question. But I was thinking, like, as you were talking, like it does require a certain type of vision. So let's assume a situation where if you were designing the primary care system from scratch in this country, like with no lobbyists, like no EMRs, no prioritizations, not all of those things, what would it look like? What would it feel for the patient who is walking in? What do you, what is the vision that you, when you have so much experience around this, when you think about it, what would you, how would you describe that vision so people can feel it as well, on a visceral level?
So first, it wouldn't depend on the person walking in. It would depend on meeting people where they are, and I divide the world for the purposes of public health into communities of 10,000 people. And I do that because that's the size at which you can create a team of people that can be available every day and every night. And, I'll save the ecology of that, but for every community of 10,000 people, in my view of the world, ought to have a multidisciplinary team. When we did this, when I was in state government, we created a proposal called the Rhode Island Primary Care Trust that built this on the notion of neighborhood health stations, sort of like fire stations, neighborhood health stations. So in each community of 10,000 people, there should be this team of probably 100 people when you put it all together. And those people include physicians and nurses and physical therapists, all the people I mentioned before, community health workers, also the rescue squad, the EMS, emergency medicine, somebody who can move people around urgently, also home health nurses. So and that community of 100 health workers ought to be responsible for the health of every single person in that place and know every single person in that place. And that and then figure out how to structure itself so it can be responsible for making sure that that the people in that place have the best measured health we can get them. I saw this, I'll never forget. Rhode Island had some sister cities in Nicaragua in the mid 80s. And I got to visit a place called Niquinomo, Nicaragua. And I went to a health center that had actually originally been built in Niquinomo by some friends and colleagues in Rhode Island. So it's always good to get a tour. No offense, but clinical facilities always look pretty much alike. They have exam rooms and waiting rooms, and there's nothing all that spectacular one from the other. This one was very nice. It had a lot of spaces for people to sit outside. But the best part of that community health center was the epidemiology room. It's a room where
It was not in a basement, because
not like right on right in the main part of the building. You walk in, and on the wall there were maps of the entire community with every household identified, and what their job was to look at the incidence and prevalence of diseases and figure out, like what disease transmission there was, where there was chronic disease, so that every single person was attended to. That's my dream.
Yeah, I love that. I love that as a vision, and thank you so much for bringing that. You and I talked about like your experience that is really kind of like a lifelong experience in so many ways. I want to ask you a really serious question right now. So you've been in organizing circles and medical circles, and like community organizing. That Courageous Clinicians community is about like enabling people, accompanying them on their journey to become community organizers, not just clinicians. So which one, in your opinion, between those organizers and medical field, which one has more egos and which one has more coffee?
That's a biased question. The coffee is all in the community organizers. But, I gotta sort of throw out a line to the clinicians, to the people who are clinicians first. And I don't think clinicians, even in the United States, are really that much about ego. I think most people who go into healthcare and medicine do it to serve people. And that's what they want, and that's what they dream of. And what happens is they get distracted, distorted. Their egos become the center of things. Sort of it's made to happen, by the
Yeah.
process we've created. And so if we created that with the process, there's no reason we couldn't create a different model and make and empower people in a different way with a different process.
I couldn't agree more with you, and that's my experience working with. Sometimes we were talking when we work with medical residents is that like students in medical school, you actually what is your work there is to keep the fire burning, because the system is actually constantly trying to put that fire out, like their passion for care, for empathy, for love, for community organizing, for community in general. It doesn't
Community.
be organizing, and it's fascinating how that becomes like that we created a system that becomes like a radical idea to keep people's passion and fire burning throughout their medical training. You and I talked about it briefly, and at some point in our conversation, I realized that you worked with, and you had a chance to work with two of my favorite kind of like people in terms of like being a clinician and being an organizer. Jack Geiger, who was like a famous person to build, healthcare.
Started the community health center movement in the United
Exactly,
States.
in the United States, and Bernard Lawn, who was like amazing clinician, but also won a Nobel Prize for his work around physician for social responsibility. So
The Nobel Peace Prize, not
yeah,
the
exactly.
not the Nobel.
How was your experience working with them, and what did you learn that we can apply to this moment in time, like in so many ways?
Oh man, it was such a gift. I mean, both were kind of happenstance, and how I got to meet them both, a little different in both settings. But from Dr. Geiger, I learned, I think, the importance of meeting people where they are. And, Jack's perspective on the world, he started the community health center movement in the United States as an outgrowth of his work in civil rights. His personal history was long and complicated, but he had an unusual connection to the civil rights movement. And he was pretty focused on using healthcare to try to equalize social disparities. And his commitment was to making sure that happened and to making sure that the community health center movement always had 51% of its boards being users of the health center. That's really where he came from and how he thought about the world, but also had a deep commitment to human rights and sort of human rights and justice around the world. Dr. Lown was, full of, he was critical, he was brilliant, he was uncompromising, and completely committed to, sort of justice and decency. And all his life was filled with figuring out how to use healthcare and medicine to get at that. He's this world famous cardiologist. He invented the contemporary treatment of heart disease. He invented the defibrillator. And yet he kept coming back to, how do we make sure that clinicians listen to patients, and how do we hold ourselves accountable to making sure that the work we do is in the public interest, not to enrich ourselves and not to. He always wanted us to think clearly about the healthcare we were doing, so that we didn't waste resources or overtreat in our own interest. And the one thing that I always carry, two things I carry with me from Dr. Lown. One was listen to people. What did he always say? He said, listen to patients. I can hear him right now. And the other thing he said was, I would, from time to time, get discouraged about how are we going to make this, how are we going to fund this? How are we going to figure out how to make this thing work? And he always would say, don't worry about the money. Do the right thing, do it well, and the money will come.
Yeah.
And that has been, really fantastic.
It's really, I think, I thank you for that reminder, because sometimes we get stuck with this, like, oh, we don't have the funding, we don't have the resources, where if you do have the people, as you're saying, the resources, people are resourceful, like all around the world, wherever they are. It's one thing to say like, oh, we can live in despair and kind of like not take action, or we can gather and then the resources will come to us. I want to read you something from a book that you might know. It's your book. And for those who are on the call, Healthcare Revolt, a really good read on what we need to do. And maybe that could be a transition. And my last question, to allow you to speak about your current work with the primary care for all Americans. So you said in this book, the movement for healthcare in America will have four aspects. Will expose and educate, We'll mobilize healthcare workers. We'll organize small healthcare systems in every community. And we'll build a national political movement, a political revolution in healthcare to pass enabling legislation at the state and local level, which means we have to organize ourselves, act up, and reorganize what we already have so that we can take care of all Americans. So I think it's a really interesting proposition. So how you are doing that? Tell us about the work, primary care for all Americans and the work that you're doing there.
Well, I wrote that book and then, it was a nice theory. And then a friend of mine ended up saying, this is failing and what are we going to do? And I said, the only way to fix it is to build a healthcare movement. And he said, to build a social movement. And he said, and I said, and that's too much work. It's too crazy. And he said, but we got to do it. And so we started. That business of the power of two. We started talking to each other. We brought other people together. And so we're working on building a social movement it's called Primary Care for All Americans, that aims to build a healthcare system for the United States that's for people, not for profit, and starts by providing primary care to everyone in every neighborhood and community in the United States. And to do this, we have to do a bunch of things. One is do the organizing work, but we also have to, at the end of the day, change the trajectory of health policy. Now, health policy in the United States is always focused around how are we going to pay for health care? Should we have single payers? Should we have this? Should we have that? And our sense is throw that out the window. Everybody needs primary care. Primary care is an essential service. Let's get everybody primary care and start in each community. So we are going, we're now in 6 or 7 or 8, I don't always know, communities around the United States. 2 or 3 of our local organizers are actually on this call, and they are doing amazing work in their own communities, sort of pulling people together and building what we call local work groups to figure out how to provide primary care in each place. Now, we've been able to reference something that has been going on in the community where I live for 25 years. It's called Scituate, Rhode Island, where it's the most Republican town in the state. And Scituate is the only place in the United States where everybody's guaranteed access to primary medical and dental care. We've been doing that for 25 years. And our aim is, at Primary Care for All Americans, to help other communities do that for themselves. And there are a bunch of different things that folks have to do or can do to get that started. Educate, like I said, sort of do a little bit of empowerment, work on pipelines and scholarships and clinical opportunities, finding ways to bring more clinicians in, all sorts of things that kind of can go on at once. And so we've got these groups of people working on this. Pam Cavanaugh, who's on, is our organizer in New Bedford, where there are like 50 people working on this thing together, New Bedford, Massachusetts. It's spectacular. And then we've also tried to organize some statewide work groups to work on state health policy with the fundamental sort of observation, and this is where we get to the national movement stuff, that when we get hundreds of local work groups across the country, then we not only start by providing primary care to everybody, which is, gives, as far as I'm concerned, gives us legitimacy, but then it gives us a political base to start to do the policy changes we need at the state and national levels to make this happen faster and better. And, our understanding, as far as we're concerned, ignore the federal government for the next 5 or 10 years, because it's going to take that long to build this up on the one hand. And on the other hand, there's a little gridlock in the federal government that we won't discuss here.
Yeah. It's really, I think what I've got inspired by when I was reading about your work and what you're proposing there is this notion that, if you're to start to make change, you need to start locally to do that. Like sometimes we neglect proximity. We tend to jump, especially I see that among the clinicians, especially, there's a immediate jump to this big, let's change the national policy. where proximity matters, or like connection to other people is how you actually create change. And we're so grateful to partner with you and with Primary Care for All Americans to actually support that kind of like educate. We expose and educate, like to really work on how do we spread the gospel of organizing among as many people who are part of it. This was really fascinating, and Michael, I want to really say like big thank you for joining us today. Michael, the final word in the 2 minutes. What gives you hope, or what is your advice? How should we approach this in the times that we're living right now? And I really encourage you not to admit us and send us home with Tylenol, but give us something substantial here, with that we can grapple. So what should we do, and what gives you hope in this current moment in time? So
I think what gives me hope specifically is watching Pam Kavanaugh work in New Bedford and having all those people come together to actually work on this together. This works. It matters, and it's doable. I didn't spend time talking about the economics, but, primary care costs nothing. There's no reason everybody in America shouldn't have it. There's no reason everybody in the world shouldn't have it. And not just any primary care where people listen. So this is a doable thing. And in terms of what's happening specifically in the United States, I will quote the great, let me finish with 2 quotes. One is Joe Hill, the great organizer, who said, "Don't mourn, organize," and which a colleague of ours, Sarah Pasteur, adopted and turned it into, "Don't agonize, organize." And finally, that great quote from the great book Rebel, even blocking on the name of the book, but it's a quote from Hannibal, quoted by Saul Alinsky, which is, "Either I'll find a way or I'll make one." And so it's up to us to make one. I don't know how to thank you enough, Pedja, or all of you, for the work you do in your own communities every single day. We can make this move, but it's going to take all of us continuing to work and working together to make it happen.
yeah. Thank you, Michael, so much, and to be continued in so many different ways. And thanks everybody for joining us today. We're going to continue doing these courageous conversations every month. And what an amazing session, Michael. Thank you so much.
Thank you all.